It's my pleasure to introduce Dr. Sandeep Mallipattu, our visiting professor this morning. Dr. Mallipattu is the DCI Martin Leibowitz Endowed Professor of Medicine and the Chief of the Division of Nephrology and Hypertension at the Renaissance School of Medicine at Stony Brook University. He's an internationally recognized investigator whose work in podocyte biology and transcriptional regulation through Kruppel-like transcription factors has significantly advanced our understanding of the molecular mechanisms involved in various causes of chronic kidney disease, including FSGS, diabetic kidney disease, and progression of AKI to fibrosis. His research has been continuously funded by the NIH, in addition to other sources, and his contributions have earned him several major national honors, including being awarded the Presidential Early Career Award for Scientists and Engineers, as well as election to the American Society for Clinical Investigation. In addition to his scientific accomplishments, Dr. Mallipattu is an outstanding clinician, educator, and mentor. He's been recognized with a multitude of teaching and mentorship awards and plays a key role in cultivating the next generation of physician scientists in nephrology. So with that, please join me in welcoming Dr. Mallipattu.
All right. Well, thank you for that kind introduction. I don't know if that's so deserving. My family thinks I don't do too much. I just sit around the house, so appreciate it. And thank you for the invitation. It's been great to be at the KRI yesterday and got to meet a lot of folks. And it's really exciting what's happening here. And hopefully some of the stuff that presenting today would be of interest. Yesterday at the Works in Progress, it was interactive. And today I thought maybe I'd have a little bit of a different direction, and hopefully, and please feel free to interrupt me. Oftentimes, we hold the questions till the end and we forget, and might be good to ask. So I kind of built in a little bit of stops along the way, and hopefully that's helpful. So this title, something old, something new, something still in motion. Because we're getting married to be something blue, but treating FSGS. I think at ASN this year, as you can tell, now I was talking to Ashley, we have so much stuff for IgA nephropathy. We don't even know which one to pick sometimes. And I think FSGS, there's still an opportunity and where we are at that. I do have disclosures that I need to reveal before I get excited or anyone gets excited. I've actually had to pay money out of pocket for these. I haven't made anything from them, but that's there. If some of you have been out to Stony Brook and Long Island, but I do want to set the stage because I think just to know, sometimes we're in different corners of the U.S. and don't really know the landscape of where everything is. And, I just really love this map because, I had my training in Manhattan, but this is actually figured to scale. This is the size of Manhattan. This is the size of Long Island. So we're at Stony Brook, about an hour on the halfway to all the way to the tip of Montauk. The Stony Brook Medical Center is a university hospital. We have the community hospitals out east, Eastern Long Island and Southampton Hospital. Most famously associated with is the Cold Spring Harbor National Laboratory. So that's where cutting edge molecular techniques is performed. And then also you have the Brookhaven National Laboratory, so supported by the Department of Energy. And so it's one of the few in the country. You have it out in California as well. And so I think it's really ripe for really basic translational research and an opportunity for potential collaborations. I just have this image on the right. So if anyone visits Stony Brook and they see this really ugly building, so this is the first building that popped up, the Health Sciences Tower, and behind is a Basic Sciences Tower. And this is during the architect was famously wanting to make that what we call the brutalist era. And so this is just raw concrete cinder blocks, the appreciation of it. I did my alma mater, starting to Simon, UCSD, so we had the Geisel Library, very similar type look. That's much prettier looking. I think it was in the movie, it was Attack of the Rotten Killer Tomatoes, like a B-rated movie, and so that's where that started. And oftentimes we run out of time, so I do want to take just a little bit of time, acknowledge really the funding sources. What I was going to talk today about is something that started with had an F-32 at Sinai award, like a fellowship award, and then went on to a K on the work, the same project, and it's been kind of linear. And then all the newer stuff has been really supported by the Veterans Affairs, thankfully, and we're fortunate in that aspect. And then a couple of the folks that contributed along the way, and I'll highlight them as we go along. And grateful for my mentor, John He at Sinai, who allowed me to take the work when I transitioned to Stony Brook, and we continue to collaborate and we're on projects together. So it's been a great period of time. So I thought I would start with a clinical case, not really a diagnostic dilemma, but more of what we would do as treatments. So somebody actually, saw along the way, I keep track of some of the patients in our clinic, in our glomerular disease clinic as well. It was a 52-year-old male presented to the hospital at the time. We saw him as a follow-up subsequently, but had 1 week of vomiting, abdominal distension, and bilateral lower extremity edema, hypertensive. He had clearly pitting edema as well. He had some degree of AKI, and he is hypoalbuminemic, and he had significant albuminuria. Underwent a kidney biopsy, and so he had FSGS, 3 out of 4, 14 glomeruli, mild to moderate IFTA, and diffuse foot process effacement. So what would be the management in this case? So I think at Stony Brook, I would ask one of the fellows what they would think. But here, you got to be careful what you ask the fellow. So I'll go ahead and say what happened to the patient, right? So first course of action, received prednisone, 1 mg per kg daily, and really responded well, like immediately, really. Within the first month, the proteinuria improved. Even the serum creatinine got better a little bit, and over time as well. Now, the second case, which is a little bit interesting, so I just wanted to just kind of contrast these two. Have a young kid, 25-year-old, came to the hospital, generalized malaise. He had also lower extremity swelling. What was interesting is when he was 15 years old, he actually was diagnosed with FSGS. He actually was put on steroids, right? He was a kid because it assumed to be minimal change disease, did not respond, underwent a biopsy, found to have FSGS, and they put him on cyclosporin. And he responded, but he was a kid, went on to college, just kind of got lost to follow-up. I think it was somehow got off his insurance, and stopped taking the cyclosporin. So presented hypertensive edema, he was more severe AKI, significant proteinuria. He underwent a repeat kidney biopsy and still found to be focal segmental glomerulosclerosis. 30% was globally sclerosed, so significant progression, right? Prior biopsy had shown about 25% segmental sclerosis, minimal global lesions, which progressed, and he had no interstitial fibrosis before, but now it progressed. So this is like clearly a progression that occurred over time, partly because either he stopped the cyclosporin and progressed. So we put him back on it, right, without much benefit. He also later on got tried on rituximab as well, but the significant amount of interstitial fibrosis progressed, and then he went on to losing his kidney, eventually got a transplant. So questions: what is the evidence behind the use of glucocorticoids in primary FSGS? And apologize for those of you who know this literature well, but I think it's something just to set the stage on. We use this the most frequently, the most prescribed medication for primary FSGS, and what are the factors that might mediate its responsiveness and other agents, right? Something new. Can we reduce the cumulative dose of glucocorticoids for primary FSGS? Is there something we can add on? What is the data behind it? And something still in motion. Hopefully there's a little bit of time to go over this. What's the current state of therapeutic strategies for primary FSGS? A little bit of work that we've been doing to build into this on where we would be coming from, but we're not the only folks that are working on this. The impact of proteinuric disease does not need to be articulated to this group, right? So we know that regardless of the etiology of kidney disease from USRDS, a significant proportion of individuals have proteinuria, and as such, and also it's built into their ICD-10 coding, and it's now used as a surrogate marker or endpoint for clinical trials, and as such has moved around a lot of therapeutics along the way. How common is FSGS, right? It's a question that comes out, and it's really hard to understand. You look at multiple studies, anywhere from 20% of nephrotic syndrome in children, 40% in adults. The primary glomerulopathy causing ESRD in the United States, primary glomeruli, not most common would be obviously diabetes or just glomerulopathy. But the largest cohort I could find was the one from UNC Chapel Hill cohort. So it's about 21,000 kidney biopsies that were reviewed. And at least during that period of time, about a quarter of those are FSGS. And these are obviously clinically indicated biopsies mixed in with primary and secondary. So not so clear completely, but there is a proportion of individuals that are on it. And here, experts in the room on the role of podocytes. We know podocytopathy is critical impact in this disease process. And for all of you know, these are these post-mitotic visceral epithelial cells, inability to proliferate or regenerate at baseline, but yet very dynamic in nature. And the scanning electron microscopy view is demonstrating its foot processes that really encompass the basement membrane, prevent the loss of macromolecules. The last 25 years has really gone into identifying key proteins that are involved in its ability to maintain this filtration barrier. And over time, and reviews written by Shanklin and work here has really shown that there is a point at which of no return. So there's a potential opportunity to repair versus once they're lost, it does result in the sclerotic lesions. We were speaking about potential mechanisms that are involved, but the critical to the entire aspect is the podocyte. So this is from KDIGO guidelines, and I was going to just go over just for those of you who don't look at this all the time, and Ian can correct me along the way on some of what we look at the evidence behind classifications of FSGS. I'm not going to talk about all forms of FSGS, really focusing on primary FSGS. But if you look at the lesions on light microscopy, we know about the genetic causes of FSGS, such as APOL1 that's involved, deficiency in coenzyme Q. And so there's actually potential treatments now. And I'm not going to go over it, chat about it after, but there are new agents coming out, APOL1 inhibitor and so forth, on those individuals that are actually would be targeted for it. Individuals with primary FSGS are classically defined as diffuse foot process effacement, right, and sudden onset in the patient that I reviewed. Obviously, the secondary causes, you got to treat the underlying, and there is a group of undetermined causes. And I thought what was really unique that actually changed over time when I was in training of progression is this chart. If you look at the left on the left side, would be that you have classically proteinuria, albuminuria defined at greater than 3.5 grams per day, but hypoalbuminuria is a key. So really, I look for that in the patients that are actually responding to therapy, and doesn't have to have edema. And that was a shift, I think, over time. And on the flip side, in those that are absence of nephrotic syndrome, the classically having both those features are the ones that you might want to work up for genetic causes, secondary causes. If they're not responding, then move on to potential need for immunosuppressive therapy. And it is important to differentiate those two because you want to be appropriate in those individuals that require the immunosuppression. I just want to keep this simple here for supportive care. I think all of you know this, and on the patients that we treat, keep them on RAS blockade. That's critical. Dietary salt restriction and optimal blood pressure control. I'm just going to keep it simple there, which is the basis of the KDIGO guidelines for treatment of FSGS today. And this infographic I thought was great, just to kind of this wheel to look at it. You have the range of 3.5 grams and greater is where the severity and part of definition of nephrotic syndrome, and treatments and all the clinical trials are focused on this concept of complete remission versus partial remission. Complete remission is defined as less than 0.3 grams, but there's this gray area partial remission between 0.3 and 3.5 grams, and also with a decrease in greater than 50% in of proteinuria from baseline as well. And why is that important, right? There's one study, and that's the Toronto registry, and perhaps there's newer ones today, but this old study really showing the impact of the need for at least partial remission. And so those that don't remit, the renal survival rate is significantly low compared to those that have partial and complete remission. So the follow-up period was about a year, 281 FSGS patients that were followed in this registry. And secondary causes, and FSGS is unknown, just to say a supportive care, treating the underlying, no immunosuppression typically is what that we would follow in this case. But what's been the problem with the clinical trials to date, right? And there's been several. The problem has been really is that including all types of FSGS. I think the newer trials are trying to move away from that, really using that definition of primary, that they could be used in these studies, or if there's genetic causes, go after those individuals. There's been limited assessment of serum albumin in a lot of these small cohorts. Proteinuria sometimes in some of these studies have been defined as just over a gram per day, and a limited assessment of foot process effacement because they didn't really characterize those to group those patients. So sometimes you get these mixed findings, and that's been a struggle in really identifying that. So something old. So what have we used, right? So again, for those of you who know the KDIGO guidelines well, we look at the stages, something that with really strong evidence, and as well as things that are level 2 weak evidence. Just to keep this in mind, I'll go over why that's important. And look at quality of evidence. If you look at C and D, D is very low. And what that is the estimate of effect is very uncertain, and often it will be far from the true effect. So D that's the definition. Now, the most common that we use, glucocorticoids, right? The first line based on the Ponticelli regimen in the late 90s, or 1999 when a study came out. So it's actually 1D based on KDIGO. The evidence is low. But because it's recommended, and also the effect could vary. And the dosing is 1 mg per kg per day, and the median duration is 16 weeks in that study, and the remission rates can be highly variable. And the study originally, the Ponticelli regimen, was a retrospective study of 80 patients, and that's where that was based on. And the duration treatment was the main difference. And the study was at less than 16 weeks, you had lower rates of complete remission. Greater than 16 weeks, you had more significant rates of complete and partial remission. This work from J. Radhakrishnan at Columbia really showed that this is the dark or the black here, combined complete and partial remission was variable in the first primary steroid therapy as well as repeat steroid therapy. And if you do respond, typically we keep patients as a tapering dose for about a 6-month period, and I think some of the clinicians here can speak to it as well. So definition of steroid resistance, right? So when you don't define it, again, persistent proteinuria greater than 3.5 grams, that infographic on the right, not having at least a 50% reduction in proteinuria, and the treatment of steroids for a minimum of 16 weeks, unable to get to that reach. What do you do in those individuals? The current data, it's a little bit better. 1C, the KDIGO guidelines. If somebody's not responding to steroids, typically keeping on for 16 weeks, they don't. In my experience, and some of you, usually the folks that are responding are within the month, you can start seeing the proteinuria reduction. But in the individuals that are resistant or contraindication or intolerant to steroids, it's calcium inhibitor, cyclosporin, and TAC, a little bit better data on cyclosporin, but for at least a 6-month period. And if they respond, keep them on for a year. But the contraindications or intolerance to steroids also similarly, minimum of 6-month treatment. And there are several studies to show this. The largest is from Dr. Catran's group, and really from the North American Nephrotic Syndrome cohorts, 12 centers, right, that they combined. One thing to keep in mind, largely white population, but on the graph on the left, you can see on the red, partial remission rates were pretty good. And combining with a complete remission rate, 70% with cyclosporin and a combination of prednisone, but 40% relapse rate at the 1-year period. So this is obviously, we know cyclosporin, it's used in the mechanisms behind it. I thought one paper was interesting, potentially the direct role in podocytes. We talked about the podocytopathy being the major cause in FSGS. Work from Christian Fowl, Peter Mundell several years ago had shown that the calcium actually, it is present in the podocytes, and cyclosporin actually, when it's blocked, it allows for degradation or allowing for dephosphorylation of synaptopodin. And synaptopodin is a critical actin cytoskeleton element in the podocyte. When that gets dephosphorylated, it allows it to get degraded by cathepsin on the right, and so leading to proteinuria. So that was some work that was done over time to show maybe potential direct effects of cyclosporin on the podocyte. I thought this was really interesting, partly to show the impact of assessing calcium inhibitors. So if somebody doesn't respond to steroids, you still think there's a component of primary FSGS, you're going to put them on cyclosporin. So the graph on the left right there, and sorry, I think this is right from the paper. So the light gray is complete remission. The idea behind this, in non-genetic causes of FSGS tend to respond really well to calcium inhibitor cyclosporin. Compared on the right here, all the dark or the black is the non-responders. The proteinuria is much less. And this is the same thing along with recovery of kidney function. This is normal eGFR on the light gray versus those that are genetic causes don't respond to calcium inhibitors or cyclosporin to help you determine one direction or another. Rituximab, I'll kind of keep it brief here, but potential benefit in recurrent FSGS, let me get to here. And this is, apologize for the meta-analysis, but just a kind of a summary to show that there's a potential role in steroid-dependent FSGS. I think it's used, and some of you have used it as a third line if the folks aren't responding or help them get off the steroids. And there's a potential role in reducing the relapse rate in individuals after they've come off steroids as well. For the transplant nephrologist, I think commonly it's used in the folks with current FSGS post-transplant would be, in a sense, you're trading in 3 times a week dialysis to once a week plasmapheresis with rituximab, and that's been helpful. But still, in the C. Jason paper, that 21% of those patients had complete remission, but there's still about 40% that had lack of response to this approach. Alicia Fornoni in Miami, also several years ago, similar to the direct effects of cyclosporin, there's potential rituximab. What they showed is directly targeting the sphingomyelinase pathway, and what sphingomyelinase is involved is ceramide synthesis, and that's their work to show that there's potential impact in rituximab targeting podocytes in the sphingomyelinase pathway and have a direct effect on improving or attenuating actin destabilization and improving proteinuria. So something new. And so I think here, we know about sparsentan, FDA approved for IgA nephropathy, right? And I think I was speaking with Ashley, I think the jury is going to come out in January a little more on the eGFR. This work from Janos Fittipaldi at USC on the left had this really elegant paper demonstrating the potential role of sparsentan, not just in improving the hemodynamic effects, but also suggesting that allowing for clonal progenitors and repair from various sources to repopulate the podocytes. And also that initially the duplex and the duet study showing this from the New England Journal, that there was a significant improvement in proteinuria with sparsentan compared to irbesartan, 40 to 30%. But what was interesting, the 2-year period followed, there was a lack of difference in GFR. So I think there's going to be, the data is going to come out soon in January, so look out for maybe the potential benefit with sparsentan and whether it's going to be approved for FSGS as well. What about SGLT2 inhibitors? I tend to add this to our patients that are we're treating concurrently. At least from the DAPA-CKD study, when they look at subset of patients with 100 patients that that were on SGLT2 inhibitors as well as FSGS, that they showed a trend towards improvement in GFR on the left here, compared to a decreasing decline in GFR as compared to the placebo. So there's potential benefit. I would tend to add it, but not a separate control study for this. The timeline for treatment, this is a nice review that was done in Kidney Medicine just last year. I just pulled this to really show the kind of graveyard of medicines we've had over the years. And so I'll remember ACTH originally, and then repackaged the Actar gel, right, which never really worked in our hands. Azathioprine doesn't work, cyclophosphamide doesn't work. Calcium inhibitors, we just talked about the potential role. Salsep, not so much. We haven't seen that effect, and some of you could speak about it as well. Not so much with sirolimus. There's some data. I mean, obviously, rituximab in terms of CD20 antibody, and now the new clinical trials that have come forth, and we'll go over that quickly in a second. So really, the history has not been great, but potential to move forward now. So something's still in motion, right? What are things that we can move towards? So I actually spent some time looking through the NephCure data set and the Neptune, seeing what the active clinical trials in the US that are enrolling. Again, talk about the APOL1 channel inhibitor. All of you know about this. It was hot for ASN, and so showing potential in those individuals with carrying the high risk alleles and FSGS. A lot of these are going to be completing very soon or nearing it. What would be interesting is metformin haven't really seen the data completely on the use of it. I thought this was interesting, the absorption device for removal of LDL particles that are bound to apolipoprotein B. So that could be a potential that's going to come through. Podocytes tend to undergo hyposilylation of proteins, so increasing the silylation could be a potential benefit. There's a CCR2 inhibitor and combination with ARB, that's chemokine antagonist that's used. Anti-CD20 antibody is interesting because, I mean, obviously, targeting rituximab was more specific towards this, and it's used obviously in membranous, but potential role here in FSGS. And the SUPAR antibody story, which I'm not sure whether it's going to pan out, but that's been obviously in the mix. And also the angiotensin 2 type 1 receptor in combination with the endothelin receptor inhibitor is also an opportunity, because I think the combination of both could have an impact moving forward. Yesterday, we were speaking about the potential role of JAK-STAT pathway and the mechanisms that might be mediating it. And this is baricitinib that's actually in play and studied to complete in 2026, and as well as a tyrosine kinase inhibitor as well. So these are all in the pipeline right now. So I think hopefully in the next year or two at ASN, we're going to see more updates on this. So just to rewind back, the approach that we took is, at least when I was a fellow, the question I had was, well, how do the steroids work? Is there a potential direct impact on the podocytes? Is there, what is a direct mechanism by which it actually could improve podocytopathy in those individuals that respond versus the ones that don't respond? And that's where really the question that I had. And we know about the complications with high dose and chronic use of glucocorticoids, hypertension, weight gain, systemic infections, bone loss. And even Jeff Kopp at the NIH tried to do an open label clinical trial for oral pulsatile dexamethasone for individuals with idiopathic nephrotic syndrome and look at the complications. There was a lot of complications that were reported with the use. And so they did observe that individuals with the glucocorticoid receptor carriers of this, if there's a variance of these, actually increase the susceptibility to use. So potentially screening for individuals for the glucocorticoid receptor would be an opportunity to put somebody on it or not. But it's always been a shotgun approach. We're going to treat a lot of patients with everyone with all comers glucocorticoids. If they don't respond, then move ahead. So the exposure has been there, and the amount and the dose hasn't really been reviewed on how we can optimize it further. So the potential direct mechanisms in the podocyte. We talked about rituximab having a direct effect, talked about cyclosporin having an effect. What about glucocorticoids or dexamethasone? The seminal study was done by Stewart over the years, and I'll just kind of go over this previously. But the biology of glucocorticoids are that it's going to translocate into, it's going to get across the plasma membrane. It's going to bind to the glucocorticoid receptor. This is classic biochemistry here. And it's going to homodimerize and then translocate to the nucleus, and it acts as a transcription factor, regulates gene expression. That's how the glucocorticoids work. Binding to the glucocorticoid receptor is what is critical for its downstream regulation. The first study was one of the groups in Ransom's group, as well as Bill Moyer, really showed, and the Japanese group as well demonstrated that the glucocorticoid receptor is present in podocytes. That was the first proof principle to show that treatment with dexamethasone increased, and apologize for the Western blots, but to show that the increased nuclear localization of glucocorticoid receptor, suggesting that it is translocating into the nucleus in podocytes. And this is also just showing the immunostaining that it gets into the nucleus. Later work here by Stewart is showing that in models and culture, treatment in models with puromycin, treatment with dexamethasone stabilize the actin cytoskeleton to show, again, direct effects that could occur in vitro settings. And more recently, work at Yale showing, again, LPS is not the best model that we use in animal models. They knocked out the glucocorticoid receptor only in the podocytes to show that it exacerbated proteinuria in these models, suggesting that there is an impact of direct targeting to the podocyte, and not to take also the immunomodulatory effects. And so again, one of the questions I had was, well, how do they work? What are the targets downstream? Glucocorticoid biology and receptor biology has been well studied. It's oftentimes used as supplements for a lot of things that we use even in the laboratory, but as well as frequently used. So I looked at other conditions, right? And so one of the groups at Colorado, and I was at a meeting where they looked at airway smooth muscle cells because oftentimes patients with asthma COPD are on short-term use of steroids, and they're looking at what affects airway smooth muscle proliferation as well as differentiation. So back in the day, way before single-cell RNA-seq, there was microarray, and they did a simple study. They took airway smooth muscle cells from patients and treated it with dexamethasone for a period of time. They looked at what goes up really early because it's a transcription factor and what goes up much later. And so what was really interesting, so they looked at a lot of genes. These are canonical genes such as FKBP5, FOXO1, and also circadian genes because glucocorticoid receptor signaling is very critical for the circadian rhythm as well. And what was interesting at that time, which I didn't know anything about, this was almost 15 years ago when I was studying this work, is that one gene that popped up, KL15, was really high, early inducible within 4 hours, and it was sustained over time as well. They went on to show that KL15 is induced early by dexamethasone and airway smooth muscle cells, and when they induced overexpression of KL15 actually inhibited proliferation. They were really looking at what affects cell differentiation in that setting. And apologize, 2 slides from compared to what we showed yesterday as well, just to set the stage. So what are Krupple-like factors, right? Krupple is the German word, very derogatory. It's the reason it was identified is because originally in the fruit fly, when they mutated the Krupple gene, it resulted in embryonic lethality. And it's considered that in mammals, you have actually 17 orthologs compared to the one gene that you have in the Drosophila. And if you look at this is a family of molecules, remarkable homology in the C-terminal end, a lot of heterogeneous nature in the N-terminal end. This is where really the differences that occur. And it's a transcription factor family, so it's also going to regulate gene expression similar to glucocorticoids. And the question is, well, when you treat with glucocorticoids, why is this gene going up really early? And that was one understanding on what they're involved in. And over time, looked at, and there are also, the question is, what are they involved in? But a better question would be, what are they not involved in? Because there are not a lot of fundamental cellular processes along the way, and we're worked on various aspects, but a critical still is cell differentiation, cell cycle regulation. It really does matter to the basis of a lot of things that we're looking in the kidney. And if you look at a PubMed cross, we work in the kidney, right? But a lot of the work is in other systems in cancer biology, cardiovascular disease, neuronal disorders, and the amount of work that's gone into understanding how these molecules work is critical. And most famously, we talked yesterday, KL4, the Yamanaka factor, one of the factors that are involved in inducing pluripotency to taking any cell to a pluripotent state. So that's where it is. And the reason, and KL15 was a glucocorticoid responsive gene. So that's where the story starts. Clinically, it was relevant to see what maybe regulated its glucocorticoid receptors expressed in the podocyte. Now, what do we know about KL15? So the original, was the first gene actually identified in the kidney, strictly in the kidney. It was called KKLF. And the reason is it was kidney-enriched Krupple-like factor. It was about 20 years ago when it was cloned. It's kidney-enriched, involved in nephrocyte development and differentiation in Drosophila. So that was interesting because nephrocytes are model systems for podocytes. While it's expressed in the kidney, it's also very promiscuous. It's expressed in a lot of airway smooth muscle cells. We talk about airway smooth muscle cells, also expressed in cardiac myocytes as well, and it's been well studied. And oftentimes, affecting the function of this transcription factor resulted in worse states or disease. And there are KL15 binding sites on podocyte-specific genes that were identified from Matthias Kretzler's group about 20 years ago as well. And what we showed before, the expression of this gene is reduced in kidney biopsies with HIV-associated nephropathy. It's a model of collapsing FSGS as well as other primary as well as secondary FSGS kidney biopsies. And the loss of KL15 exacerbated proteinuric diseases. And so what we showed, and this is work that was published in JASN some time ago, to show that when you take cultured podocytes that are differentiated treated with dexamethasone, you get an increase in KL15 expression. So that was the first to show, in a sense, recapitulating what was done in airway smooth muscle cells. And we went on to show, this is a cartoon schematic, to show that the glucocorticoid receptor, once it's homodimerized, gets to the nucleus, actually binds to the promoter region of KL15, they're actually glucocorticoid response elements, and directs its transcriptional activity. And so the way we showed is that if you mutate its binding region, KL15 expression does not go up. So there are direct links between glucocorticoid receptor and KL15, and that was shown. But why do we care, right? Yes, we know glucocorticoid signaling, what impact does it have, right? So we went on to show if you knock out KL15 only in podocytes, and this is used working with Stewart's antibody here to induce nephrotoxic serum nephritis. And when you take the knockout of the wild type mice, you treat with dexamethasone, and his model, it showed an improvement in proteinuria. But when you knock out when you knock out KL15, the effects were mitigated in podocytes. And these are representative histological lesions, and these were quantified, and we looked at in a couple of different models. What was interesting is it was independent of the systemic anti-inflammatory effects. If you look at IL-6, a lot of glucocorticoid mediating anti-inflammatory products, they're both down systemically, but knocking out KL15 in the podocytes mitigated the protective effects in the kidney for dexamethasone in this model. We went on then to collect kidney biopsies from at Sinai as well as Stony Brook, and looked at the time of biopsy, patients before they got put on steroids to see what the expression of KL15 was, and they were put on steroids. The ones that responded had a higher expression of KL15, podocyte specific, as well as glomerular KL15 compared to the non-responders. So potential suggesting lack of responsiveness to glucocorticoids was associated with reduced glomerular and podocyte specific expression of KL15. So now we have, John, he years ago was looking at retinoic acid signaling for podocyte. That was a hot area for a period of time before the toxicity and so forth just never could be overcome. We know about glucocorticoids as well, right? Still shotgun approaches. Now that we know KL15 mediates the effects of glucocorticoids in the podocyte, how about targeting KL15? So first we looked at genetic induction. I think, it was actually a guess to try, because usually when you overexpress the transcription factor, you don't know what all the secondary effects are going to be. So, but we tried. So what we did was we generated a construct. So what this is taking the human KL15 gene, and in a system where you use doxycycline inducible system, we can induce its expression specifically in podocytes, and we can turn it on and turn it off. And so what we showed that these mice are viable and fertile when we induced this expression in podocytes. And we went to a classic model. We looked at it in a couple of different models, but some of you know, we don't see high event anymore, which is a collapsing FSGS because the treatment was antiretroviral therapy. But we've had this model originally early 80s that was described is these are these TG26 mice. So they express the viral genes, Neph and VPR, but not the infective components, GAG and POL, and they really recapitulate collapsing FSGS. So the model is that they get nephrotic range proteinuria and FSGS about 4 to 6 weeks of age, and they have mortality about by 12 weeks, and they start to die by half the mice do. And that we had shown before in an old paper in JBC that the expression of KL15 was low in these models. And we said, well, why not? Can we induce expression there, right? So the first step was to show, and just to focus here, this light gray, this is proteinuria. This is the TG20, the HIV1 transgenic mice. The proteinuria continues to increase. The black here is the mice we turned on KL15 expression. And you already have significant proteinuria. And what was interesting is that the proteinuria really dissipated down. And it was surprising because it's just with induction of KL15 in the podocytes. And you had an improvement in kidney function, which is also important. Oftentimes it's just proteinuria that we see, but not necessarily improvement in kidney function. And the mice survived. And so the induction in this model really showed an improvement in podocyte health number, but also proteinuria and fibrosis. And our histopathologist that we collaborate with, Dr. Degatti at Columbia, really characterized the scoring for this and showed that, typically in this model, you get severe sclerosis, tubular-interstitial fibrosis, you get this microcystic dilatation, and that was really markedly attenuated in this process. So why is this occurring? So we went on to do at that time bulk RNA sequencing of isolated glomeruli. And just to show, and then you look at what are target genes of KL15, a lot of these are canonical target genes. Just to highlight a couple, right? NPHS1 and NPHS2 are genes, NPHS1 right here, that are involved in the slit diaphragm processes, right? Inverted formin 2 was initially identified by Martin Pollock to show mutations in that cause FSGS, CDKN1C, CDC14A. A lot of these are targets in Wilms tumor 1. And for the fellows that's always on the board, Wilms tumor 1 mutations associated with nephrotic syndrome. And so I think to show that these are potential genes that are regulated directly by KL15. So you have glucocorticoid signaling, downstream KL15, and whether this is a regulator of these processes, because there aren't direct GR binding sites in a lot of these genes. So just to summarize work that was done over the years, but really what we showed is that KL15 works in concert with Wilms tumor 1 and affect target genes down the road. So these are these coherent feed-forward circuits, not positive feedback, but really coherent. There are genes that are directly targeted by KL15, and some are mediated to WT1, but they're both required for podocyte homeostasis. So we shocked about these. What about pharmacological induction? I think Raj asked the question yesterday. I was like, can you target one of these KLFs, right? And so that's really what our work has been since around the COVID time in 2020. We kind of started this process and we kind of moved along the way. And this is the work that have conflicts of interest. And that's what I wanted to show a little bit of where we are. So what we spent time was developing a reporter assay. So we used a classic, it's not the best model, but this is what we have in the field. We have these cultured human podocytes that can be differentiated. And what we did was we generated a cell line that had the human KL15 tagged to a luciferase reporter. And what is really cool about it is that what it means is that if there's anything that turns on KL15, then we can measure by luminescence the activity of KL15. So it's a screening method that we use, thinking that that's going to be a good readout. If you genetically induce KL15, there's protection. If you knock it out, it's worse. So why not? Why can't we screen molecules that could induce KL15? So we went on, just a summary here. We used a diversity set at the NIH, at the NCI. It's not the biggest library. It's about 3,500 compounds. And it took us a while to develop the assay because you have to optimize the signal to background ratio, the Z-score. Went on to have about 44 hits initially that had some induction. Went on to then have 16 hits that had like low EC50. So I think some of you who are, if you're in drug development or in pharmacology, the definition of an EC50 is a minimum concentration to have a 50% increase in the activity of your target. So versus IC50, if you have like a kinase inhibitor, which we're going to get to, is a 50% reduction, or the minimum dose required for a 50% reduction. So working with our medicinal chemist from this, we identified 3 leads that are potentially druggable based on its chemistry. These are the IC50s. What's interesting, the lower the better. These are nanomolar concentrations. And dexamethasone is actually higher than that. And same thing with retinoic acid. So we went on to work with Bhaskar Das, who's a medicinal chemist who's at University of Buffalo now. And he utilized these 3 leads and optimized further to improve its druggability. And we screened a lot of compounds from that. We identified 3 additional that had induction of KL15 and were safe, meaning it wasn't toxic to the cells. One of these, BT503, had really low EC50, less than 10 nanomolar. The lower it is, that means less you need to have the same effect. And we also showed when you knock out KL15 podocytes, the effects of these small molecules were mitigated, suggesting it's going through KL15. What is the structure of this? So it's a urea-based derivative, fairly small molecule. So I'll go over on how this might work. That was in vitro stuff, and we conducted these in a couple of models. And so we looked at here using going back to that TG26 HIV-1 transgenic mice. So what I want to just show here, this looks a little weird, but if you take a look, the red here is the proteinuria from 8 weeks to 10 weeks, the progression over time. The y-axis is actually a significant amount of proteinuria, and there's high variability in these mice. Some kind of stay highly proteinuric, some kind of increase significantly. But what was interesting, if you looked at the change from the start of treatment to the 2-week period, we just did a short course. These are the TD26 mice in the white that continue to have proteinuria, and these right here with their BT503 treated. So there was some reduction in the proteinuria, but not complete. Right. But what was interesting is you have an improvement in kidney function, which I thought was exciting at that time compared to not just complete restoration of proteinuria. And this is a full kidney cortex right here. The red, it's maybe hard to appreciate in the back. There's all the protein cast that you're seeing. There's some improvement that we're observing. And you had the quantification, about a 50% reduction in sclerotic lesions, but not a complete recovery that you had with the genetic induction. And what was also, if you look at using a Masson's trichrome strain, right? Not a pathologist, but blue is bad, right? Blue is collagen. And so you can actually see here less collagen deposition here with the BT503 and also less alpha smooth muscle actin staining. So we had this data, and then, the V actually supported the technology to IP it, and we'd go to, and, companies would ask when they would present it, be like, well, how does this work? What's a direct mechanism of action? Is it actually binding to kill? How does this work, right? So we spent, a few years really trying to figure out how this might work, and really stumbled, couldn't really figure it out. So we went back to a simple assay that we did, and it actually showed something interesting. And just to take a couple of minutes of your time, let me see, where are we at? I want to make sure. Okay, it's a couple of minutes. So here is, we went back to that human podocyte cell culture line, right? And so on the left here, so these are podocytes that are not differentiated. They're like immature state. And in 37, we move them, they become a bit more differentiated, better model system. When we treat with BT503, the effects are only observed in differentiated mature podocytes, but not in a de-differentiated state. So I thought that was interesting. And so we then looked at, just did RNA sequencing to see why is this happening? Why is this only in the differentiated podocytes? And if you look through and looked at all the transcripts that are regulated, what's the pathway that might be regulating? The top came up as this NF-kappa B1 pathway. And a lot of NF-kappa B involved in anti-inflammatory processes and so forth. But what was more interesting, if you did a simple Western blot, we looked at all the machinery involved in NF-kappa B signaling. The one protein that was uniquely expressed only in differentiated podocytes compared to de-differentiated podocytes is this IKK beta. And I'll talk about where that is just to summarize, because the whole system is a bit complicated, but IKK beta is a kinase that allows the dephosphorylation of the dimers to make it for the NF-kappa B dimers. And I'll talk about it in a second. So that was interesting. So only in the podocytes that are differentiated, IKK beta is present. So then we took, and the IKK beta structure has been solved. So we worked with, across the street at Stony Brook, the computational biologists that work on molecular docking. So they took the IKK beta structure and see whether this can potentially model to see can it fit in the ATP binding pocket. And so they were able to show that it can potentially fit there in the ATP binding pocket. That's where kinase inhibitors tend to target. And they had strong residues interaction with the cysteine and the aspartamine domain of the ATP binding pocket. So they're direct interactions that are there. Again, these are modeling. And so then we work with Navjot Pavla at Ohio State. And what he has is really cool assay, and it's done for cancer biologists here a lot, but is that they took the IKK beta protein and they created what they call a gatekeeper mutant. It mutates the ATP binding pocket without affecting the structure of the protein. And what was interesting, when you mutate that, typically BT503 inhibits IKK beta, so it's a kinase inhibitor, but when you mutate it, the effects are lost. So we know it's binding at that site. We also did stuff like thermal shift assays show that the protein actually physically interacts with IKK beta. So that was exciting, because to show that, okay, we actually know where it's working and it's a kinase inhibitor potentially. We also went on to do this nanobret assay, which is in cell. That's in a test tube. So this is in cell. So in a cell, this is data we haven't published, but is that using typically there's if you look at the target IKK protein, you can develop a fluorescent probe that when it binds to it, it's going to light up that we know the activity is there. But if you then add an inhibitor, it competes out that site and the signal is lost. And that's what we see with treatment with BT503. So just to summarize, so what we have here on the top left, and apologize if it's small, but this complex right here, it's called IKK alpha, beta, and gamma. This is the kinases that are required to phosphorylate. So kinase phosphorylate, right? Phosphorylate the I kappa beta. So typically what the I kappa beta is, it tethers the NF kappa B dimers, the P50, P65 in the cytoplasm, keeps it there. And so typically this needs to come by, phosphorylate it, then it allows it to this gets degraded and allows for P50, P65 to get into the nucleus. And so what we show is that it gets into the nucleus and then it binds to the promoter of KL15 and suppresses, and that could result in podocyte loss. That's typically how it works. So what we showed is that BT503 binds to IKK beta, prevents its inability, it prevents its phosphorylation activity. So it's a kinase preventing it to do that. So it keeps the NF kappa B out of the cytoplasm, the dimers. These are plots to show that and to convince. So that was showing that that's there. And so what questions really remain, right? One, could we use a combination, BT503 and glucocorticoids, maybe reduce the amount of dose that's needed? What's the impact of NF kappa B and GR signaling? And there's old biology, and I'll show you that just quickly right here. And what are the potential immunomodulatory effects of BT503? We talked about its effects in the podocyte, but what about the systemic effects? So this paper is literally 30 years ago to today's date. I looked at the publication date. So what's really interesting, this old paper was really seminal to really show. What they did was they added REL-A, which is the NF kappa B protein P65, and they kept it stable. And then they added glucocorticoid receptor. And what they see as they added glucocorticoid receptor, the occupancy of the NF kappa B to its target sites came down. So glucocorticoid receptor is actually competing out NF kappa B for its negative effects potentially. And so here on the right, also a paper from recently from Nature Communication showed that there are glucocorticoid receptor binding sites where NF kappa B sits. So potentially when we're giving glucocorticoids, are we actually blocking the NF kappa B pathway? And so if you have an inhibitor for NF kappa B, maybe you don't need to use as much glucocorticoids. And so this is just work here just to show preliminary data. We haven't done this, is that to add more to it. I'm trying to do this with animal models now, is that when you add dexamethasone, the combination of BT503 and dexamethasone further increases KL15 activity. So maybe we don't need as much dexamethasone. So I'm going to stop there, otherwise it'll be information overload. So take any questions. Thank you.
Yeah. Excellent talk. I mean, illustrative in some ways of how basic science can then lead to innovation to therapeutics. Still a long way to go.
Yeah.
What in your assessment of the next steps?
I think, there are a couple of things that have been brought up, right? One is what folks are interested in is looking to see whether can this be the combination of use, whether can you use this alone versus in combination with glucocorticoids, right? That's one. Number two is what we often get is like, can you look at some larger models, like rat models of FSGS tend to be a little bit better than the mouse models that could be used. And the other is, when we met with, they have these, if anyone works with the FDA, had these early meetings, these pre-IND meetings, and they gave us what they want. The biggest thing is, so we've done a lot now, is the pharmacodynamic PK profile, which I'm not talking about here, the safety, toxicity. And so that's what they're interested in, to make sure it's safe, non-toxic to use. So we've done it in animal models, it looks safe. The other thing is tested in organoid systems, but they actually like that, the FDA more compared to even animal models, now to look at cell toxicity using human iPS cells for organoids. So those are the two phases that we're really working on now, so to move that forward. So
just for people in your audience, human studies are X years from now.
I guess if you use proteinuria as a surrogate marker, if we can get it to phase 1, it can start this soon. So I don't know, a few years, 5 years, I would say. I don't know. People here probably have better ideas as well. Yeah, Bino, sorry.
Yeah, well, since you brought it up, I'm curious if you tried this compound or any of these approaches in human organoids, where I think the podocytes that form are very different in their morphology and gene expression compared to sort of the immortalized podocytes that are more commonly used, I would say, for screening.
Yeah, so we use an organoid system. The problem is we don't have a good readout to see at least a kind of a really something that could be quantitated and consistent across. So what we've used so far is used it as a readout, like a metabolic readout for the entire organoid using seahorse. So you see that protective effect there. It's not toxic as I increase the doses. I can look at NF-kappa B signaling in that. So in terms of by Western and staining and qPCR. So those are the things we've done. So really used it for cell toxicity. I don't know if you have a way of having an actual readout for podocytes and that could use.
When I first saw podocytes in organoids, right, it was like over 10 years ago.
Yeah.
I was like, FSGS is going to be huge. This is going to be so useful for FSGS,
Yeah.
right? And that first paper had an FSGS sort of phenotype in it. But it really hasn't materialized.
Yeah.
We don't have that smoking gun phenotype yet in the organoids.
Yeah, and it's the struggle that's why I've used it more as a toxicity screen using human cells. But and so we were stuck with animal models for now. And it's kind of nice work with FDA because they actually tell you point A, what do they want in order to move this forward. So so we're moving ahead. So yeah.
Just thinking about the safety and toxicity, how specific is this compound in KLF15 question? And then how do you go about thinking about the safety and toxicity evaluation?
Yeah, so we did a combination of two so far. You actually work what's actually the best to do safety toxicity is not to do it in your own lab, to send it out to CROs. So you send the compound and do a screens like looking at assays like human erg assays, so that looks at the cardiotoxicity. You can deliver toxicity profiles. So they do it and they give you a report unbiased, so rather than doing it in your lab. So that's what we've done. Number two is then you can test in animal models at increasing doses and then get the organs and then look at transaminases, troponins, all this stuff to look at those. So those are the two combinations that are there that could be used. But that's what the FDA is looking for, those specific assays. And so that's really that. Yeah, so I think it's the other way around. I didn't have a chance to show this. I'll just take 1 second here. So you can actually do this kinome library screen. So we sent this out. So because BT503 targets IKK beta and then downstream is KL15, that's really the mechanism behind it. So what was interesting right here, the degree of BT specificity to IKK beta inhibition. So you can actually send this out. You can actually do this as a library screen at 1 micromolar concentration of BT503. They screen 400 kinases, see if there's any activity. In the red here, it's about 90% inhibition. If you zoom in, there's a few kinases out there. So you look at this, it's IKK beta, one of them, TKB1, X. So it's in the kind of the same family tree. Not 100% specific, but so I was a little disappointed. Okay, it's not as specific. But then talking to our experts in kinase inhibitors, what they did was look at this paper on the in Nature Immunology of all the FDA-approved kinase inhibitors for various cancers and the lack of specificity that you see. Oftentimes, they're not going to be 100% specific because they're targeting the ATP binding pocket that could be variable across these kinases. They said this is actually not bad, but I think the jury's out. You have to test these and look at these more. And the final thing what we did was, which I don't know yet, and that was a really good question you asked, is what we did was there's a lot of NF-kappa B inhibition is not novel, right? Folks have tried this. And the reason it's failed is because of the toxicity associated with it. There's actually about 20 known IKK beta inhibitors in the market. So we took all 20 and screened them for KL15. And so a lot of them are, for IKK beta inhibition, because that's what they were supposed to be, IKK beta inhibitors. A lot of them aren't specific. That was interesting to see. And then from those, we looked at 11 that showed some degree of inhibition. From that, the level of IC50 inhibition was not so great. So we used the threshold about 200 micromolar. From that, there were 7 that came out. And then we screened these. only 4 came out. 3 of those were pretty toxic. And we looked at the remaining 4, and then we then said, well, what about KL15 expression in those? The only one that increases KL15 is BT503. The other ones didn't. So, but I don't know why. And so that's where we're kind of stuck at right now. So, yeah.
I appreciate the ongoing challenges of trying to identify an efficacious therapy that also is non-toxic. And one thing that we've learned in transplant care and cancer care is that minimal doses or liquid doses of multiple drugs are being safer. You showed in your ITK data profile that downstream of that inhibitor is also a ubiquitin pathway. And I'm wondering if you thought about targeting ubiquitin as another component to the multi-target inhibition.
No, that's a great question, because one of the problems with transcription factors, they're really short-lived. Really KL15 is induced early, stays on, and it goes down. And so that we know the half-life is about 30 minutes or so, but as you have these pulses. That's all you need for most transcription factors. So the fact that the expression's up, is there any potential ways of combining these two would be important? But that's a really good question. Yeah, Ron. Yeah.
Great talk. So what's happening to the tubes? So because part of the NF-kappa B has been implicated in polar and red cross tubes as well. So could some of the beneficial effect in the animal model also be not only in the polar side, but abrogating some of the injuries?
Yeah, no, that's a good question, and I think folks like Catlin, Shustak, and Trober have shown the NF-kappa B activation models of CKD and so forth. I think the part that was interesting is that you do see overall less, because it's when you use a molecule, you're going to see less NF-kappa B activation across. We do see that in the tubular compartment as well, and so that's why I think it's interesting, because you also see less tubular injury and overall interstitial fibrosis. So it might be a good thing, but yeah. Yeah, sure.
On work, Sandeep, it's great to watch from fellowship to where you are now.
Yeah.
It's quite a tour de force. Can you just tell us what you know or speculate about KL15? What is it doing at the podocyte? Is it limiting cell death, attachment, acting cytoskeleton, all of the above?
Yeah, so I would think of it as the most similar transcription factor to KL15 to some degree is WT1. So in a sense, the question I would say is whatever WT1 does, it works in concert with it. So WT1, it regulates everything. So that's what I would say.
Great talk. I was interested in your slide where you showed the human kidney biopsies where you measured KL15 and saw mucoid steroid responsiveness. Is that something, as you're working on the therapeutic approach, is that something you could use now to make decisions about whether patients should get steroids?
I think it would be great, I think, to look at it, because I think the antibody, there are a lot of commercially available. So we have to actually, they were not specific, so made a specific antibody for it. So that could be used to stain. I think sometimes you look at, who's following the work and so forth. So I think that I looked at the last NEFSAP that Richard Glassick wrote, and he actually has a line for KL15 that could be glucocorticoid responsive. So potentially that could be used. I think it's just the antibodies are not so commercially available. So I think it's an opportunity to stay and see if their expression is low. Perhaps they're not going to be as glucocorticoid responsive. So, yeah. So.
Thanks. That was great.
It's hard to follow your talk. So.
It was just interesting. You did this with something old, and you had like cyclosporin and MAP and steroids, and everyone chose them for their modulatory effects. These were after the cause of FSGS, and then you showed no, it's nactoprodin, no it's neuromyelinating, and no it's KL15. So is immunomodulatory therapy for FSGS? Do you think there's a future there?
Oh, no, I think it's critical. I think they're just both are required. I think I was just trying to say is you could have the immunomodulatory effects, but some of the effects are direct to the podocyte. I think that was the center I'm getting at. And I think with Stuart Schroeder, a long time ago that really could have that the glucocorticoid receptor is expressed in the podocyte. So. Yeah, and I think to be honest, that's why I think you're not going to necessarily get away. The agents that we use, I think, have to be able to modulate both. So glucocorticoid receptor signaling, NF-kappa B modulation is going to be critical for the change in the inflammatory profile. So I think that's going to be in combination with the potential direct effects. I think just individual to it may be much more difficult as long as this has an effect. I think a lot of these are affecting the podocytes together. So. Yeah. Yeah. Literally just moving. Yeah, I mean, I think it depends, and that's a good question. I just don't know the answer. I think that's the problem is, it gets a bit of a band-aid, right? It's going to reoccur when you stop. So I think the combination is whether you could use these to actually deplete the source in combination with plasmapheresis. So, but some of these agents, I think the point was it's not just working on the immuno. I think in combination, I think you need that for FSGS, primary FSGS, not secondary. Anything else? Well, thank you. Appreciate it.